Great. Okay, so we've got 2:30 here, so I guess we will get started. So good afternoon, everybody. And my name is Holly Standhart, and I am with MPRO as part of Superior Health Quality Alliance. I am a senior quality consultant. Superior Health is the state quality improvement organization for the state of Michigan. I will be the moderator for today's event. So I want to welcome everyone to the policy breakout session. I hope everyone has been enjoying the virtual conference so far. And as a reminder, before we begin, we ask summit participants to turn off their video and sound until the Q&A period, and that will be at the end of the session. And at this time, we will open the lines for any question, and at that time, we'll open the line for any questions that you might have regarding the presentation for today. All sessions will be recorded and they will be available after the virtual session as well. So I want to give just a quick session overview before we get started. And so let's begin. So COVID-19 brought about policy changes that seem to be implemented overnight, specifically related to substance use disorder. And those changes included expansion of telehealth services for SUD treatment and support, loosening of restrictions for how providers can initiate and sustain medication-assisted treatment, and increased efforts to divert individuals with nonviolent SUD-related offenses out of jails and prisons to limit exposure to COVID-19. Many of the changes that happened so quickly had been a focus of advocacy groups prior to the COVID-19 pandemic. In this session, we hope to explore how policy related to SUD is coordinated between the various levels of government. In this exploration, we will examine how we can build on the lessons learned from COVID-19 to sustain momentum in enacting policy that expands access to services that support SUD recovery. So before we begin, I would just like to take a moment to have our panelists and take a second to introduce themselves. And I will go in order by first name, and we will start with Andrea Taverna. Andrea.
Hi, thank you so much, Holly. My name is Andrea Taverna. I'm a senior advisor at the Michigan Department of Health and Human Services, responsible for opioid strategy. So that means coordinating within MDHHS to ensure we have an effective opioid strategy, and then working with other departments through the Michigan Opioids Task Force.
Fantastic, thank you. Next, we will move on to Joe Coyle.
Hi, good afternoon. Joe Coyle. I'm an epidemiologist and manager in our Communicable Disease Division at the Michigan Department of Health and Human Services. And my interest in this topic is in implementation and sustainability of syringe service programs, their association with hepatitis C infection and other bloodborne pathogens is some of the work that we do at the department, and using that as justification for why we need these programs statewide. So pleasure to be here.
Great, thanks, Joe. And next is Paige Fultz.
Hi, my name is Paige Fultz. I work at the Michigan Health and Hospital Association. I am the director of advocacy here. One thing I always like to tell people is, find your passion and hope they intersect kind of thing. I moved to the Hospital Association from the House of Representatives because one of my passions arose after my dad had a liver abscess and one of our Michigan hospitals saved him. So I was already involved in politics and decided to make the move over to healthcare. And I've been at MHA for about 13 years.
Fantastic. Thank you, Paige. Last but not least, I've got Seth Eckel.
Hi, everybody. Seth Eckel. I am an epidemiologist with the State Health Department. I've been with MDHHS for almost 8 years, working in a variety of communicable disease programs, and my most recent position is that I manage our viral hepatitis surveillance and prevention unit. So we're a group of epidemiologists and preventionists that work mostly on hepatitis C, but we also, in the most recent few years, have been working on the state's investment in syringe service programs. So the overlap there being that hepatitis C is transmitted quite a bit nowadays by injection drug use, and overlap in SSP to prevent that transmission.
Great, thank you. Thank you, everybody, for introducing yourselves. So we're going to get the conversation started here, and I have a few prepared questions for our panelists. So jump in at any time if you're wanting to give any information. So our first question: many of the policy changes enacted as a response to COVID were previously advocated for prior to COVID. Have we seen any evidence that these changes have produced a negative outcome? And additionally, do we foresee these changes to be permanent?
I'll start us off again with this.
Okay.
So one of the pieces I think is it's too early to tell if something is negative or not. I had mentioned the big piece is we were all kind of shoved into an experimental pilot project, when typically you take a very long time to plan a pilot project piece by piece. And with COVID, a lot of stuff had to be done quickly in the best interest of patients and ensure patients received care. We are currently kind of in the eye of the storm, I would say. So the first surge happened and then summer came and fall is on its way, which is the typical flu season we are used to. So that is the basis of it now. I think that it's going to take time for us to see, and we'll, vet those pilot projects that were put in place during this time and see what was good, what was bad, and how we can make it better. And at that point, I think we also can evaluate what should stay and what can go. I do think, the lessons that have been learned in Surge 1 will carry on for the second surge that's happening. But at the moment, it's just too soon. It hasn't even been a year since COVID hit the state. I believe March 10th was our first, and DHHS could probably was the first case we had here within our borders.
Thank you. Great insight. Okay.
I certainly agree with that. Very much agree with you, Paige. We've heard very positive feedback so far from stakeholders and some treatment providers around the flexibility that's been offered in medication-assisted treatment and how you can offer that service under the federal regulations. Again, it's extremely early to tell. We're still in early days of COVID, and particularly trying to resolve what changes stay in the steady state. The really big question is what the new normal looks like now, not just for COVID services, but for MAT. And I'm certain that Joe and Seth can speak to SSPs.
Sure.
Yeah, I mean, I can jump in and Seth can finish this one off. I think in terms of policy changes related to SSP under COVID, there wasn't really a ton. The one thing that we were really encouraged about was that SSP was determined to be an essential health service. So programs could remain open and continue to deliver services during the pandemic. And, I think just having that declaration in and of itself was really positive. It's a really positive message for our programs. It demonstrates how they really are necessary. And I think for us at the State Health Department, when we're trying to implement new SSPs, our message is always that we think these programs, like the entire population of the state of Michigan, if they need clean syringes, they should be able to get them, and they should be able to get them from a syringe service program. And so we think it is an essential health service. We always have, and sort of now having that really official designation, I think is just really important for us. And I think, there have been a lot of recommendations related to how SSPs should modify their service delivery given the pandemic, whether those recommendations came from the Harm Reduction Coalition or CDC or others. And I know we have definitely encouraged, while it wasn't really a policy change for us, it might have been a policy change, protocol change for how those programs operate. And Seth can probably tell you a little bit about how things have been modified, but I think overall, service delivery actually didn't go down much at all in terms of the volume, right, Seth?
Yeah, I think that's right. What we saw for the most part is that obviously there were barriers to accessing services. The number of client encounters seemed to have gone down, but the number of services delivered in the terms of syringes going out the door, naloxone kits, was increased per client visit. I think that leading into the pandemic, kind of conventional wisdom was this is going to have great impacts on the community of need there, right? That we might see decreased access to services, and there might be more overdoses, and there might be less naloxone available, and, more fatalities, and, maybe it remains to be seen that we'll have more infectious disease consequences too. And I think the data is kind of coming to fruition there, that we're seeing and hearing anecdotally from our Syringe service programs that indeed has been the case. So that's pretty challenging, knowing that there's already a large community of need that we're trying to deliver services to, and then we have COVID on top of that. So I think that if there's definitely what Joe said about that designation is incredibly important for our program, and I think important for the SSPs. If there is any silver lining, I think that's come out of COVID from the SSP side of things, it's that programs that are trying to deliver services in this environment have had to think outside the box a little bit. So what's working, what doesn't? Let's try some new things and see how we can reach the population in need during the times of COVID. And I think that they have found, by and large, a few models that have seemed to work depending on the SSP and their community. I'm thinking one that's been successful for a couple sites is trying to actually reach out to directly and deliver services to the clients where they're at. So these things might be extra tools that are in the toolbox when, COVID comes back again, or we have a second wave in the fall, or who knows for how long, or maybe they're just better service delivery models in the future too, depending on the population for that particular SSP. So,
yeah, I mean, it's almost exactly what Andy said, right? Like, what is the new normal going to look like? I don't know what the new normal is going to look like for me getting groceries in the future, but I've gotten used to the method that we use right now, and it's not that different from how people are utilizing these other types of services too, right? Like, we have a lot of SSPs that might be doing service delivery by appointment. They might be distributing materials via the mail. So maybe that's something that becomes more of a norm. And to the extent that it continues to keep people safe and keep them healthy, then I think we certainly endorse it. I think this question asked a little bit about negative consequences, and I really can't think of any that we've heard related to the SSP side of things.
Fantastic. Thank you. Thank you very much for that insight. Okay, we'll move on to the second question we have. So going forward, what are the current efforts in coordinating public policy as it relates to substance use disorder? Do we expect to see more changes in policy as a result of COVID-19 pandemic?
Certainly, I'll dive in there. A few efforts that we have ongoing. So a core aspect of my job is coordinating within the Michigan Department of Health and Human Services. Folks may know we're a 14,000 person organization. We're the merging of two different health departments. So it is quite a bit of effort to bring everyone to the table. So we have Medicaid, children's services, behavioral health, public health. I think that's the main stakeholders, but it's a pretty substantial set of people and cross-cutting. So there's a lot of coordination just to get ourselves on the same page. And these are, not to belie the point that these are sometimes controversial and difficult policy decisions to make. We then also have the Michigan Opioids Task Force, which was created by the governor to essentially create the same structure across state government. So we have a table with essentially all of the state agencies that work in this space. We have a stakeholder advisory group where we try to get input from impacted sets of industry, from clinicians, from advocacy organizations. We've tried to be quite broad in getting that input, and then work on a series of public town halls to hear directly from the folks we're trying to serve about how the opioid epidemic is impacting them. I will say that's kind of all at the state government level. There's this key question of how we coordinate with local governments, with local criminal justice systems is a big place where this comes into play, and then local entities like hospitals or advocacy organizations. Michigan's regional behavioral health system of Medicaid is also another key point of intermediation.
Thank you.
Yeah, I mean, I can go next just because it kind of segues nicely into where Andy left off as it relates to SSP. we have had a state law that has prohibited SSPs from operating in our state for decades, right? So some programs have existed back into the 80s and into the 90s. I think where we have seen the biggest barriers in SSPs starting up have often been with local policies. And so I think our group has worked very closely. Again, we think we should have SSPs everywhere. So we're trying to find communities where there's the biggest need, but also, the lowest barrier to entry into implementation. So where we have found areas with big need, sometimes this isn't also an area that might have policies that are resistant or resistant to having a SSP operate, related to the local drug paraphernalia laws or ordinances that they have. So our work is really to coordinate with the local entity to approach those conversations with local leaders, policymakers, law enforcement, to see if we can modify what the local ordinances might be to help pave the way for SSPs to be successful. And, I will just throw out that there are many areas of the state that do not have drug paraphernalia laws that would prevent SSPs from operating, but that doesn't always mean that in and of itself means that an SSP should operate and will be successful in that particular jurisdiction. We don't ever want law enforcement or the policymakers to be surprised that there's an SSP operating in their jurisdiction, right? I mean, these are things that need buy-in from the community, from the leadership in those areas. And so, just because something can be implemented doesn't mean that it always should be. And it's really important for us to work on the policy level to make sure that there are as few barriers to implementation as possible, but to also make sure that the programs are set up for success.
Fantastic.
Yeah, I mean, I would just add that as we've had a lot of these conversations over the past couple of years, I think more often than not, the municipalities or jurisdictions that we approach, once the partners are brought together and we have those conversations and we can do education and everybody's on the same page with what SSP is, how it's beneficial and what we're trying to accomplish, I think they're more than amenable to go to the process at the local level and change those ordinances to allow exemptions or remove those ordinances, whatever's necessary, to have an SSP operate there in a manner that's like safe for the clients, safe for the staff, and the legitimacy of the program. But man, that's a lot of steps and that's a lot of work to be done to arrange and have those conversations, even in the best of circumstances. And then when you add COVID on top of that, that makes things even more difficult, harder to arrange partners, just a myriad of things. So that's the situation that we find ourselves in. It would be great if, policy-wise, hopefully at some point in the future, we can streamline that process. Though Joe said, we would want to have those conversations anyway. We would want to have all of our SSPs and do that education at the local level so we get the buy-in and establish those partnerships really from day one when the door is open for the program. So.
Yeah, I was just going to add really quickly that, a lot of the work that we're doing right now is in southeastern Michigan. And I mean, back when before COVID, we would always be going to, we traveled all over the place to meet with city councils, mayors, law enforcement, chiefs of police and sheriffs in different areas of the state to help sort of make the case with our local partner that's looking to implement SSP to see if we can move those conversations in a positive direction. And we continue to do a lot of work in Southeast Michigan, and it's kind of nice not to have to make that drive back and forth many, many, many times. So in some respects, the working remotely has been okay, and we've been able to get, I think Seth has recently met with folks in Lincoln Park and Inkster that were really supportive of implementing SSPs locally and changing ordinances, productive conversations in Oakland County and Monroe County that are ongoing now. So we can have all of those conversations from the comfort of our remote workstations.
Fantastic.
I was just going to add to the end of the question that you had asked, which is related to, do we expect to see policy changes as a result of COVID? And I think that the answer is absolutely. I think that lawmakers will look and try to evaluate, besides us, what went well and put it in law. I also think that some of the executive orders that people were very supportive that Governor Whitmer put in place, I think people will be looking at moving those and putting some of those into law. So in the future, that won't happen. I know technically the pandemic is supposed to be every 100 years, but even some of the glitches that they're having between the two types of laws, where how you can declare a state of emergency and whether or not the legislature, has to approve it. I think those are going to be real conversations that they're going to have after the pandemic has settled too. It's very heated right now, and to have one of those honest debates about the good policy changes for the people of Michigan for when the next pandemic hits, that's, to this level, putting those in place from what we've learned now, I do think those conversations will happen. I think there's going to be conversations, obviously, right now for immediate need, but looking in the future to make it easier or harder for the governor, or, the same thing with the legislature, but those real conversations will be had, for many years to come.
Thank you for that insight. Great insight. Okay, I'll move on to the next question. So a little bit of this was covered, but as new strategies and approaches are being implemented on a consistent basis, how can we ensure that all policy decisions at all levels are coordinated to provide the best opportunity for success? For example, the state has increased funding to expand syringe programs, but no legislation action has been taken to restrict enforcement of drug paraphernalia laws. Anybody like to address that?
Yeah, I mean, we can start because I think, SSPs was specifically called out there. I don't know that always the barrier isn't always necessarily on the policy side. I think I alluded to that a little bit in the last question, is that the state law does allow for SSPs to operate. It has for a number of decades. We know we've had successful programs that have existed for a long time. I think what probably has moved the needles the most, has been just the sentiment changing around substance use and harm reduction as a component of a comprehensive opioid strategy in local areas, and access to syringes, access to naloxone. I think that sentiment has changed over the last few years. I also think the availability of funding has changed. Only in the last couple of years has the state of Michigan provided funding to local agencies for syringe service programs. And that's also a component of federal policy too. It wasn't that long ago that that there was a ban on using federal dollars to support SSP, period, hard stop. That changed under the last administration, and we still don't have necessarily specific funds from the federal government necessarily that are carved out for SSP, but we can use our opioid strategy dollars to fund those agencies. And now that we're able to do that, I think we have seen more interest and more, in terms of locally implementing programs. And I think we've grown from 4 programs that have existed in our state for a number of years, with traditionally no support from the federal government or from state government, at least for the syringe service component of their program, versus now having 25 plus agencies in our state that are distributing syringes. So I don't know if it's as much a policy barrier as it is just a barrier to the will and the determination and the funding being available in local agencies to implement. So that would be sort of my answer to that part of the question.
Yeah, I mean, I would just add as kind of an exclamation point on what Joe was already saying about policy supporting SSP on the federal level, that even under the current administration, like the ending the HIV epidemic has SSP as a pillar within that, and the CDC pushing through viral hepatitis and specifically hepatitis C Prevention and Surveillance is really pushing and supporting SSP. I mean, they even have a full website, which I think is cdc.gov SSP. So a lot has changed in just a couple of years.
Wow. Great.
I think in terms of how we can coordinate across levels of government, there are a few different aspects of that. The state government being honestly better communicative partners, so communicating out our strategy and our rationale for making different decisions, and also getting that feedback before decisions have been made. So I'm very frequently involved in conversations with stakeholders, trying to understand, our decisions on the ground, but absolutely no one is perfect. State government is not perfect. We could do that much better. I think there's also getting at the state to local distinction as well. The exact same kind of scenario plays itself out. So I think we could be better about articulating out our strategy and then finding places where I catalyzing change at the local level and getting folks on board with your strategy, or ways that your strategy. So I'll let Joe and Seth continue talking about SSPs from the NAT side of the house. In Northern Michigan, maybe that looks like starting with Vivitrol or starting with Suboxone instead of getting all the way to methadone. There are different levels of comfort, and we need to both recognize that and also find places to move the ball forward. So I think what you'll see from MDHHS is trying to be a lot more transparent about our strategy, articulate it out, create spaces to speak with the public, and also explain out our rationale in much more depth. So we've been putting out written documents like you wouldn't believe. Yeah, I'll leave it at that. Maybe Paige probably. I think you have a different perspective that's extremely helpful to hear.
No, I think that just as far as it goes with strategies and coordinated efforts, I had taken a different approach when thinking about this question. Working in the hospital system, it was more how hospitals within a system coordinate together is more the approach that I had thought about when we had discussed a little bit earlier. And I think the big pieces are when you have a large health system, you're able to share resources and pull resources and have more of a coordinated effort along those lines. If you do tap into other ideas along those, for talking about state and federal, the Michigan Health and Hospital Association, we're a part of the American Hospital Association. So that would be, a coordinated effort there. All 50 states do have, and DC do have, a hospital association that works with the American Hospital Association. So I think coordinated efforts along those lines. I also think people sometimes forget how large health systems can be. We have multiple health systems that actually are located also in other states, not headquartered in Michigan. So that's another piece too. So while we have state resources that are located in our state, if other systems are able to tap into resources across the board to help on a more expanded level there.
Yeah, I'll just add real quickly to this too. Is we communicate with our syringe service programs on a regular basis. We have monthly calls. We check in with some of them even one-on-one more frequently than that. And we try to have our ear to the ground to a certain respect with what they're telling us and what they're experiencing, and making sure that if we think that there's something there that is a policy change might help, we'll bring that to the table and see what we can do about that. And I think this is one of those instances in which the state drug paraphernalia law, while we think it is able to permit the syringe service programs from operating, and we think that it preempts local laws that might be in contradiction to that, that's not always the experience that our syringe service programs have when they have gone to implement a program locally. And so we'd like to add, through policy change, through legislative changes, to add clarity to what the state drug paraphernalia law is, what it specifically allows, and how it relates to ordinances at the local level that might contradict what the state law says. So yeah, I think we try to be responsive to the needs of our programs because ultimately we want them to succeed. And if they're identifying barriers that don't allow them to do that, or don't allow them to deliver services in the way that's evidence-based, then we're going to do what we can to see how we can help them on that front.
Great, thanks. Thank you for that. Okay, great. So we'll move on to the next question. Is policy versus practice taken into account? With recent LARA regulation mandated changes, many SUD providers don't have the funding to meet new social detoxification requirements. Anybody like to comment on that?
I'll start off promoting DHHS's listserv.
There you go.
So I think that the big pieces is you know, practice and policy can't always go hand in hand. I think that people get ideas on what policy should be and what laws should be, not only from their own heads, but experiences that happen and they don't always line up. So the biggest way that you can get involved and ensure that practice and policies do line up is to get online and join not only DHHS has a great listserv that I'm a part of, but LARA has one as well. I'm a part of DIFs for insurance purposes and different things like that. And you actually can customize your own settings on what you want to learn about and hear about. And if you don't like what you see, you not only get timely alerts, but in there it includes in emails if there's a public hearing on a topic you're interested on and how you can get involved and how you can let someone know that practice and policy don't necessarily line up. And they are oversharers in a good way, not just, you know, all departments. I think more information is better to have than not enough. But I think the underlying piece is, I think everyone really is trying to do the best that they can with the information they have. So until you educate and take the time to educate someone, whether it's a lawmaker or someone who does work in state government, you can explain your side of the story and work with them to influence policy. The same thing with lawmakers. They have coffee hours in district. You can talk with them, chat with them, look up their emails and phone numbers online, and you can have a real impact on making sure policy does line up with practice. But does it 100% line up? No. And so there's processes in place where you're able to express where you think there's a gap for that. So I'll stop there.
And I'll pick it up because that's the perfect transition to the example of the LARA social detox regulations specifically. I do know that's a topic that has come up very frequently from the provider perspective. There was very strong feedback from the provider perspective about that regulation and the feasibility of implementation. So I think Paige really hit the nail on the head in saying that practice and policy don't necessarily always line up, and there are some instances where a policy purposely makes a change and is trying to push practice into a new direction. There are some cases where there's just a bit of a communication gap and the necessary information wasn't gathered ahead of time. And that's exactly why this coordination and the stakeholder feedback is so important, is that we do try to look, we try to speak to the affected people, we try to look at the data, but your decisions are as good as the information you have. And it is sometimes difficult to gather the information that you need to make an informed decision, especially, you know, we're talking about COVID here. If you're moving quickly, there are places where it's particularly challenging.
Fantastic. Okay, we're going to move on to our fifth and final question. Thank you. So what resources can we share with individuals who would like more of a voice when it comes to creating public policy? I know, Paige, you had mentioned a few resources. I didn't know if there were any others that you could suggest.
I think one I didn't mention, so I'm a big fan of the listservs because I like them on my phone to come to me. Great bedtime reading. No, I wasn't really insinuating they were boring, but I think another one I really like is LARA. It's housed on LARA's website. It has the list of the rules that are up and the process, where they are in the process for the rules. It posts the public hearing dates in case you want to comment. So that's a resource. And then I am a really big fan of Meeting Your Lawmaker. not just from working in politics, just in general, especially local level lawmakers. It's a big impact. They typically live fairly close to you, but I like when constituents offer to be a resource for lawmakers. If you go to a coffee hour, they're typically not, super busy, and it's very easy at the moment to go to coffee hours because they're all virtual. So you can sit in your, family room and have a virtual coffee hour with your lawmaker and just say, hey, in the example of healthcare, you could be like, I'm a physician assistant, I'm a PA. If you have a bill related to PAs coming up, please feel free to shoot me a note or ask me a question so we can align practice and policy. Or if you have a question about how PAs have a role on a patient care team in my interaction with a physician or something along those lines, it is the perfect opportunity to offer yourself as a resource. So just going back to question 4, that really would make it so policy and practice line up from the beginning, and you're, not necessarily backtracking. But, lawmakers don't come into office with a list of PAs that all live in their district or physicians that all live in their district and things like that. So making yourself available and being willing to have those conversations with lawmakers, I think, is extremely important. Also, if you have their ear, it's a good time if there's something that's bugging you related to any topic, whether it's COVID or opioids. I mean, this is where lawmakers are they're the only ones with the power to introduce a bill. Even if you have a bill idea, a lawmaker needs their name on it. So that's one of the reasons. Also, if there's a bill you like or don't like, lawmakers also are the only ones that can hit that green button on the floor. They're the absolute only ones who can vote. So discussing and talking to them really, I think, makes a huge difference. As someone who worked on campaigns, every vote does count. I grew up in West Bloomfield, and that district is 50-50 split, no matter how you slice it. West Bloomfield is very, very progressive. People are in the middle, and a lawmaker I worked for only won by 181 votes. You can't tell me that a vote doesn't count. I mean, they get really, really tight. It was a 0.2 margin. So, definitely make yourself available and vote on November 3rd coming up here. That is the biggest, easiest way to be a part of the process is voting if you don't want to join a virtual coffee hour.
Yeah, I mean, Paige and Andy know more about this than I do. I'm just an epidemiologist, but I think for us, I think policy that is informed by the people that the policy impacts is really important, and I think that's where we need to lend a voice to people who are impacted by substance use or people who use substances, period. I think there's still a lot of stigma around that, obviously. And I think that's part of what we try to do at the state level is figure out mechanisms through our programs or our communication strategies that help to reduce stigma so that people that are in this group are able and comfortable with voicing their opinions to lobby and to advocate for legislative changes, for policy changes, because I think that can be just tremendously impactful. I mean, when you're introducing a bill that's going to impact nurses, you want to hear from nurses. If you're introducing a bill that's going to impact on substance use, it would really be great to hear about people who are using substances and hear from them. How will this impact you? How is it going to impact your community and your life? And I think we just don't have enough individuals right now who are really comfortable enough with standing up and lending their name and their voice to that. And I think we want to try to empower people to be part of that conversation. I think we're really encouraged by some of the work that at least I'm aware of that's going on the west side of the state related to drug user unions. So, and I know these have been really powerful groups in the Northeast of the United States. So people who use substances that can meet with legislators and policymakers to help discuss how they feel about, not being able to be eligible for jobs because they have a felony on their record or something like that, right? Being able to advocate for themselves as the impacted community and really demonstrate how the policies that exist impact on them. And I think there's some of that work that's just in kind of its infancy on the west side of the state and really formalizing that group. And I'd be honestly very excited to see them at the table in some of these conversations related to policy changes and existing policies that impact on people who use substances.
That's great insight.
Yeah, I was just going to say that Paige's answer got me fired up, and then I think that that's all relevant to SSP as well. And initially I wanted to just say, get involved, reach out to an SSP, start being involved in the work that we're doing. But Joe raises a really good point that there's a very important group of folks who have a voice, and we need to hear it. But there are barriers and stigma in the way from them sharing their voice. Now, I do think that SSPs are when they're run well, and I think ours are, they're very in touch with the community, and the longer that they're established, the more that they can be in touch with that community and make things comfortable for them to share that voice. I think that that's something that is definitely on our radar. We know that we've had a very top-down approach to implementing SSP in our state. The state of Michigan and MDHHS has embraced SSP, included it as a pillar in our state's opioid response plan. And we can find partners and we can open the doors to SSPs, but there's only so much that the state health department can do. We really rely to be successful on partnerships at every level, and I think that that's one that we need to definitely support and kind of build those relationships at the community level. And I think stigma reduction as a whole is something that we're going to have to tackle to get us there.
Absolutely. I have a question about that. So if a community is interested in implementing SSP, who are you hearing from? Are you hearing from law enforcement? Are you hearing from advocacy groups? Who's usually reaching out to make that initial first contact? Or is it the state saying, hey, we see the data, this is what's going on, we highly recommend that you do something like that? I don't know if anybody has any insights on that.
A little bit of all of that, honestly. Sometimes we look at the data and the disparities are such that it's like we need to have a conversation and we need to start somewhere. Oftentimes for us in communicable diseases, that conversation starts with the local health officer. And they may be able to point us in a particular direction, especially if they have like a opioid collaborative or something in the area that might be appropriate for those types of conversations. So sometimes those are initiated by us. Sometimes, though, it has happened a few times when there's been members of the community just said, like, there needs to be an SSP here. I can do it, just like an individual. It's like, well, I don't know how to contract with you, but maybe we can figure something out here. And sometimes it comes from a community-based organization or the local health department. Sometimes, we've heard once or twice from the clinical community. They're interested in it, the recovery community. So it really depends. I think a lot of it can be, we look at the local opioid sort of groups that might be operating and seeing if SSP fits into their plan locally, and if there are interested parties that might be relevant to sort of offering those services, what their sentiment is and their readiness. And part of our job is to identify who the right partners are and make sure that they have all the tools, policies, procedures, trainings, et cetera, to implement the program and be successful.
Fantastic. Thank you for that. Okay. Well, thank you everybody for all of your insight and wisdom on this topic. Before we open the lines for our participants to ask questions, any departing thoughts or anything you'd like to add that you think should be addressed?
I did mention it before, besides that November 3rd is election day, so please vote. But just reminding people that in 2018, the state of Michigan voters by 67%, large amount, passed no reason absentee voting. So you can actually go online and get an absentee ballot and submit it. Due to COVID, this is a safe way that you can be comfortable and vote from your own home. If you're uncomfortable with mailing the ballot back, a lot of clerks have put safe boxes out. There's actually a list online where you can see where you can drop off your ballot in person in a safe lockbox for that. And just reminding people that Michigan does have a safe option. This has not been challenged in court. Other states are scrambling, trying to figure out safe ways for people to vote, and we do have one of those. Ballots haven't even necessarily gone out. Mine hasn't yet in where I live here. So there's plenty of time to quote unquote order one. There was also a ruling recently by a judge that as long as your ballot, if it's mailed in, is postmarked by November 2nd, it actually still will be counted because there's 14 days to election results to be certified. There's always nuances, but it is counted. So do take the time to request a ballot if that is how you choose to vote.
Great, thank you. Thank you for that great reminder.
Yeah, I just, one thing I think I might have forgot to mention in one of the previous questions is related to policy and practice. And, it's just, it's a complicated system of government that we have. I think it can be a little bit convoluted, and despite the best policies, often the enforcement is going to be at the local level, and there can be, there can be a disagreement between what the policy says and what the practice is, and we've seen it. Our SSPs see it. I think what's crucial is we have those lines of communication open with the programs, so that when they see something that is inconsistent, they can raise that to our attention, and we can figure out how to best handle that in partnership with them. I think a good example, we've heard this from one program, is that actually one of our long-standing syringe service programs is that there's continual turnover of law enforcement officers, right? And so they need to be continually educated and reminded on what the local laws are and what the state laws are, what's permitted, not permitted. But sometimes things get lost in the shuffle, especially with new hires. And what they had found is that some of their SSP clients were being picked up. They had syringes on them, they had naloxone on them, and those things would be confiscated, and the person would be put in jail for a drug paraphernalia related charge. And the judge would immediately dismiss it because that's legal and that's permitted in this particular area. But it just goes to show that there often can be differences, even when the state law and the local law permits something to happen, that the enforcement is local, and there can be inconsistencies there. It's not uncommon, and that we just continually have to work towards making practice mirror what the policies are. And to the extent that we can make very explicitly clear and universal, like if we could have a universal policy that doesn't matter where you are locally in the state of Michigan, that everyone's being treated the same way, I think that would help streamline things quite a bit. And so that's what we're trying to do on the legislative side.
Great. Thank you for that. Okay, well, we have a few minutes left here, so I'd like to open up the lines for our participants to ask any burning questions that they might have regarding our content or anything that related to policy. So certainly you can unmute your line if you'd like, and if you do have a question, if you can state your name and your organization, that would be great. And also just a reminder, we do have a chat function as well. So while we wait for any questions from our participants, just want to, oh, there we go. Hi.
Hi, my name is Julie Cushman, and I work at the School of Social Work. I teach at the School of Social Work. I used to be out in the community for about 22 years, and so I'm always interested in keeping updated on what's going on. One of the courses, I teach a lot of the policy courses, and then I also I'm teaching a social justice and diversity course. And so Paige, I know this isn't completely related to what we've been talking about today, but are there things that graduate students can be doing around the election? Any activities that they can get involved in to get more people out there to vote? That's one of the things that I'm looking for my class, to find some activities that they can get involved in so that our vote is successful.
Yes. So number one, you have the perfect group for social media. So even if COVID did not exist, your group, graduate group, I'm assuming I went to grad school right out of college, so I started at 23. I'm not sure your age range there, but social media is where they can be the most involved and the most vocal, not only with hashtags, but ensuring that proper real information is being shared. That is number one. So I would say to definitely have them get involved in the social media aspect. Number two, individual lawmakers are always looking for assistance. So you would be able to have them reach out to campaigns to see what they're doing. Why some people are choosing to do door-to-door, which door-to-door canvassing would be something during COVID. I think that particular piece is less, but they are looking for individuals to make phone calls on their behalf, send text messages. I get a lot of text messages all the time, but we're in Michigan, which is a hot button state, of course,
Yes.
not as hot button as Wisconsin, but I also am a mother of 2 young kids, and I can be a swing voter, so people always want to get my vote and get an opinion. Also, I respond to surveys and polls, so people love getting me on the phone because I want to make sure polling data is accurate, so I actually do take the time to respond. So that's another piece too. If someone does reach out with a survey, whether it's through mail or text, if they're willing, and regular text messaging would apply. But I would say make sure that they're answering it. Right now, I think a lot of people are pretty nervous that polling data is inaccurate. Obviously, it was incredibly inaccurate in 2016. So
that depended on what polls you looked at, because
that's
I was
true.
watching polls that said a whole different story, so I was not as surprised as everybody. But go ahead, keep going. This is good.
Yes, I guess I was I was fairly surprised with the outcome of the election. But I think that those are another way to get involved. But if an individual graduate student, MHA even has it on our website. It's called Hospitals Act, but it's open to the public. You put in your address. We don't record your address or anything like that, but you put in your name and your address, and it actually will give you a full list of who your lawmaker is, state, federal. It even gives you all the way down to your local newspaper if you want to check that information. At that point, then you would be able to see who your local lawmaker is for state and Senate and reach out to be more involved. But number one, I think, especially during COVID times, is social media in that piece of it. And if there's particular candidates that they support either side, I always encourage voting because I, think that both sides should always be heard in a story. Have them get hashtags and join the conversation. Another piece that I think is slightly underrated are Twitter chats. Many campaigns do host Twitter chats. And that's another piece where I think being involved and getting opinions are worth it. Twitter chats are fairly boring if you only have the candidate sitting there twiddling their thumbs. And just like a panel here, they would have pre-planned questions, but they do want to reach their voters and they want to know what their constituents actually care about. So, non-planted questions, real questions that are coming from constituents. Again, it's related to social media, but have them join Twitter chats because that's what they're doing.
Great. That's really, really helpful. And I think the social media is excellent. My 2 classes have chosen to mostly be online. I only have like 4 or 6 from each of my classes that when I do an in-person class. So I think the social media will be really, really good, as well as everything else you said. So this has been very helpful.
Great. Any other questions from our audience? Doesn't look like we have anything in chat just yet.
Paige, I wonder if you could repeat where we could find that online resource to find our representatives.
Yep, so there's a state one, and DHHS might be able to help because I only know MHA's. But if you go to MHA's website, which is www.mha.org, they're actually here. I'll just make sure I do it along so I give the proper directions. But there's an advocacy tab that we have on there, and it actually is called like Hospitals Act. Let me just open it and I'll be able to tell you. So there's a tab called Issues and Advocacy, If you click on that, you'll be able to see we also do, I'll plug this, we have an opioid and prescription drug epidemic section as well. But if you do go under that, you are able to look up your individual hospital, your individual lawmaker. There's something called the Legislative Action Center. And on the left-hand side, it's the second from the bottom. And if you click it, that's where you'll plug in your address. It asks you to, take a look. What you would do on the right hand side is where you would put your individual information in. It's under Find Officials. This is also if there's a big issue happening in MHA, this is where you would find if you wanted to sign up for alerts or something along those lines. That part in the middle is blank because we don't have an active campaign. But yeah, on the right hand side is where you're going to put your Find Official is where you're going to put your address in. And like I said, we don't track it or anything. It's a very basic search, and there's multiple of them out there. That's just the one I know of, but the state of Michigan has one as well.
Great, thank you so much.
Thank you for that. Any other questions? Actually, I do have a question. It's about the Syringe service program. So are most of our counties and or regions covered in our state for syringe programs? Or, because I know you mentioned, I think there were 25 programs currently. So I don't know how that's distributed across our state, but are there areas where we still would need to focus, like Northeast or, Northwest or Southeast?
Yeah, I mean, I guess I could go first on that one. I think a lot of our strategies had been, at least initially, to fund local health departments.
Mm-hmm.
And the funding is flexible enough that the local health department could run the program themselves, or they could find a community-based organization to contract with locally. So the LHD would function as sort of the pass-through. But the reason why we had that is local health departments are obviously critical to sort of advancing conversations in their areas and supporting the programs. And they're going to have the data to support a lot of those programs too. The health officer has a powerful voice. So yeah, most of our local health departments now, I would say, have funding for syringe service programs, but many of the local health departments are district health departments, right? So they actually encompass multiple counties. So for District Health Department 2 or District Health Department 4, they cover 4 counties apiece. Mm-hmm. Do we have a program in every one of those counties? The answer is no. So we do think that there's still plenty of room for growth in terms of access to programs. So usually when the amount of funding that we're providing to a given local health department, they can sort of start one syringe service program. And I don't know that they're going to position it as best as possible to serve their community. And so they'll probably look for their most densely populated area where they have the most hepatitis C infections, for example. But that doesn't mean that they're serving the entirety of their geography necessarily. And there still can be gaps in terms of individuals being able to travel to the syringe service program. Mm-hmm. So many of our programs are now figuring out mechanisms by which that they can have mobile units so they can move around in their geographies a little bit better. Of course, as I mentioned before, we think syringe service programs should be everywhere. We think every community that needs one should have one. But that doesn't mean that we have enough funding to be able to support a program everywhere. And so we do have to prioritize. We've been using a data-driven approach to being able to do that. And I think, some of the areas that we have prioritized for expansion in the next fiscal year include some of the suburban areas in southeastern Michigan. I think I mentioned previously Oakland County, Outwayne County, Monroe County in particular, which are all areas that currently do not have a single syringe service program. And then Southwest Michigan, I think we still see some gaps there geographically. So we've been working hard for probably a little over a year, close to a year, to opening up a program in Kalamazoo. But other than that potential program in Kalamazoo, the majority of Southwest Michigan doesn't have another syringe service program. So trying to make sure that we can fill in the gaps. But actually, the northern lower peninsula and the upper peninsula are well covered, I think, by syringe service programs currently. The data suggested that was the biggest need. We've seen the highest rates of hepatitis C in those communities and vulnerability to hepatitis C infection and outbreaks of bloodborne pathogens amongst persons who inject drugs in those communities. So that had been a primary focus of ours in the first year that we had funding available for SSP, and exactly trying to expand where there's the biggest needs beyond that.
Great. Thank you for that insight. Thank you. Okay. Doesn't look like we have any other questions in chat, and we're actually up at the hour here. So I just want to thank everybody for attending today's session as we close out. And thank you again to our panelists and our participants. And we certainly hope that you've enjoyed the conference so far. And again, all of the sessions will be recorded and available after the conference. So thank you again, and enjoy the rest of your day. Take care.
Do you know if we go back to the main group now?
Yeah, Allie, I don't know if you could provide some guidance on that.
Yeah, sure. Actually, nope. Then the day is over as of now.
Oh.
So, yeah.
Okay.
And Julie, just so you know, I did send it privately. I sent you my through chat, my email address in case you had any more questions or needed to follow up with me.
Great.
So I did send it privately, but then I don't know I can't tell if you got it. So I just wanted you to know, but feel free to reach out to me if you have any questions.
Okay, great. I'm not seeing it, but that doesn't mean it's not there.
Okay, well, I can give it to you now if
Okay.
you'd like. Sorry, Holly. And Allie,
That's
I'm
okay.
holding here.
You're fine.
But my email address is P for Paige, last name F as in Frank, ULTS @mha.org.
Great. Thank you so much.
Yep. And just, too, we do at the Hospital Association provide like educational to classes, educational presentations. They're information only. They are not partisan. If you feel the need, we're happy to do that as well and speak at one of your classes. It'd be virtual, obviously, but Grand Valley reaches out to us frequently and things like that. We're happy to give nonpartisan presentations about what's kind of coming up in the political landscape. So
that's really good to know.
Yep, we're happy to do it, and we're a nonprofit organization. We do it for free, so it's not like you'd have to worry about a charge or something. It's completely offered free of charge. One of our lobbyists would do it.
Great. Thank you so much. And thank you for all the updates I got today on what's going on in the world of substance use disorder.
Great. Well, enjoy the rest of your day, Julie.
You too.
Thank you, guys.
Thanks, Paige. Thanks, Allie. Thank you.
Bye, everyone. Thank you.
Goodbye.